All right, good morning, everybody. Here's that test everyone said they were so excited to start taking in a month from now. So me and Dr. G, we've been giving this now for a few years. We're going to go through a little bit about what this is about, but really it's the idea that right, the in-service is coming. It's coming in 4 weeks. It's February 24th, last Wednesday. We'll give you more specifics in an email, but really the goals of this today is just to do a little review of really what you should be focusing on, maybe a little bit on how to study for it. Hopefully you've been studying a little bit for it already, but usually we gave this the week before the in-service, and we got a lot of feedback that it might be more beneficial to give it a little bit earlier to highlight some things that maybe you can start working on in the last month. So we're going to try to go over some test taking techniques, but really we're here just to practice answering questions with all you guys and show some of the thought process on how to tease things out and start to prepare yourself on how to manage a test like this. Right, so what is it? It's 225 questions that you get up early in the morning to come in and maybe spend up to 4.5 hours to take here. So it doesn't sound very fun, and it's not necessarily very fun, but it's really important because the goal of this exam is to give you an idea of your chance of passing the boards on your first try. That's really the metric that the that this in-service test does before your boards. It'll compare you to other trainees of similar levels, so PGY1s to 1s, 2s to 2s, and so on and so forth. And it gives you an idea of maybe which areas you need to study more on because they break it down by system. The test covers kind of proportionally the topics that are listed in ABEM for your boards that'll be tested. So the heaviest hitting topics are cardiovascular, trauma, GI, respiratory, and infectious disease with signs and symptoms, with a smattering of everything else. And we kind of give a little example today on how that might be broken down. 30% is going to be critical, 40% will be kind of emergent conditions, and 20% are kind of fast track, less urgent, with 10% not really related to disease states or patient presentations. So you're going to need to study these topics, and by focusing on the heaviest hitting topics when you're studying, you'll get the best bang for your buck. If you focus a ton on just endocrine or immunology, you're not going to get a lot of questions on the test for it. So part of this is to highlight which ones you might need to look at the most to get the best score on your test. But when it comes down to it, you could know a lot of the information and really know your things well, but you could still get a lot of questions wrong. It's an endurance test. You have to do a lot of questions in a row. You're staring at a computer screen. And sometimes the way that it's asked the questions can be tricky. And that really can delineate whether or not you get a question right or wrong, is if you read the question right, picked up on the subtle clues, made sure that you're not missing or getting tricked by something in the question stem or in the answer choices. So as we go through questions today, we want to highlight, when applicable, how you can use different test-taking techniques to get the answer right, even when you might not know the medical knowledge that they're trying to test. So what are we going to do today? We're going to do a little Jeopardy. We want to do seniors versus juniors, is how we've been doing it. This is the first time doing it over Zoom. So I would love to ask if everybody, especially at home, could please volunteer, participate. We're going to go 1-to-1. And this is really actually not like Jeopardy at all. As you can see here, we have one question for every topic here. Whoever volunteers first for their side can pick whatever topic they want. These questions are going to be multiple choice questions. You don't have to answer in the form of a question or anything like that. Everything's going to be worth 1 point. If you don't get your question right, the other team has the chance to try to answer it and steal your point. So you want to try to get it right. You can try to talk with other people on your team through Zoom and things like that, but we're a little limited on time. So I'm going to really just be whoever volunteers, or if I have to call on you, just try to think it through and try to pick their best answer. There's a couple double Jeopardies hidden in here, which are worth 2 points that we'll go over. And at the end, I have a couple of high yield final Jeopardy questions for some extra points. So,
I just want to say one other thing before we go on. The thing is, again, besides studying topics, very important to do a lot of questions, as was mentioned. And you want to do it from good question banks. I particularly like Pierre, but Roche is good too, and Coach is getting better and better. And we really urge you, and Dr. Hassel has really made an effort and pushed to get it, and that is to have a good mock exam. And I think you should all take the mock exam it's worth 2 hours of credit, but it's more worth that it will give you stamina if you take it as it's supposed to be, and you take the whole exam, and then you'll get the answers at be after it. It's 100 questions, better than the Roche one, which was like what, 225, 250.
Yeah.
So do a lot of questions at this point, especially as you only have a month left.
All right, so the juniors have been perpetual winners, I believe, of this every year. So can I get any junior at home on Zoom to unmute yourself and volunteer to pick a question? And volunteering early is beneficial because you have full range of what you want to answer.
Yeah.
If not, I'm going to pick somebody. And EMIM 3s, you're considered seniors today. Congratulations. Let's see. Diaz, are you there?
Yeah.
All right. Sorry, you're my first victim here. Pick any topic you want to try to answer.
Trauma 1.
Trauma 1? All right. So a 50-year-old female presents to the ED complaining of chest pain and shortness of breath after falling down the stairs. The nurse notes that the patient is tachycardic and hypoxemic on arrival, but the blood pressure is normal. You get the following X-ray. So what is the next best step in management? And if you need me to go back, I can go back.
I think D.
D is correct, right? So this is a pretty standard question. A lot of the trauma questions will be fairly bread and butter. This is a pretty bread and butter one. And right, you can see a tension pneumothorax here. The key is, let's say you look at an image on the test and you don't really see anything wrong at all. This happens to me plenty of times when I'm doing pressure questions. I don't really know what I'm seeing, or maybe the image quality is not very good. When you look at these answers here, they kind of guide you to what they're trying to suggest, right? All of these are choices for possible pneumothorax management. So if I looked at these and I wasn't sure what I was seeing on an X-ray, I can go back and say, oh shoot, there's that pneumothorax. And that's happened before on the exam where I didn't see something, I looked at the answers and then I went back and realized, oh, there's actually sub-Q emphysema. I was looking in the lungs and didn't see anything, and I didn't look out in the periphery. So that's one of the techniques to kind of go over is, if you're not really sure, look at what the answer choices are kind of styled towards, and that might guide you. Now here, you know it's going to be a trauma question on the test. They might have different answers that are related to different topics. And you're not sure, is this going to be an ID question? Is this going to be a cardio question? So by looking at what answer choices they're giving you, they might guide you to what it is. So good job. Now, Diaz, you can pick any senior in the chat to do the next question. 1 point. Everything's 1 point.
Yeah, everything's 1 except the double is 2. And the finals is 3 each.
Trevor.
Trevor? All right. Sabrini. Sabrini, you there? No, then...
Trevor's there. Trevor, are you muted?
He's there. He's ready to go.
Can you?
Yeah, we can hear you now.
All right. I choose Final Jeopardy.
No, you can't do that. Yeah.
I'll do HE1.
With HENT1?
Yeah.
Okay.
All right.
A 52-year-old man complains of eye pain and redness. His fluorescein exam is shown below. All right, so look first, like a lot of these questions, you want to read the question and then look at the thing. Don't look at the thing first. So, and then a lot of them are always kind of what I like to call 2 parts, right? You not only have to know what the diagnosis is, but there's another part, like in this case, the treatment. So you have to concentrate on both. So here are your choices: topical prednisolone, valcyclovir PO, Diamox IV, ceftriaxone IM with azithro PO. So what do you want, Trevor? What do you want to pick here?
So I'm going to say B, valcyclovir.
Okay, so you're right? This is classical picture of dendritic lesions of herpes simplex keratitis, right? This is actually the classical one. You don't always see it clinically like this, but they'll, on the test, give you classical stuff. So you don't have to worry about these little tricks. The treatment should be an oral antiviral drug, and you can use the antiviral drops as adjunctive, but you need to use an oral, or in bad cases, maybe even a parental, which would be acyclovir. And steroid eye drops should not be used because it makes H. simplex infections of the eye worse, which this is.
All right, good job, Servini. Pick on a junior.
Let's go Carly.
Oh, thank you.
What do you want,
Let's
Ray?
do respiratory one.
Respiratory one.
Right. The most widely used ventilatory strategy in acute asthmatic patients aims to accomplish which of the following? A, patients are hypoventilated, maintaining elevated PaCO2 to keep their airway pressure at safe levels to avoid paratrauma. B, patients are hyperventilated to bring their PaC2L levels back to normal. C, the initial settings are no different than those for a patient intubated for coma due to a drug overdose. And inspiratory flow rates are set very low and tidal volumes are very high. So one thing you always want to think about when you have questions like this is, if you're not sure, and these can be complicated, try to eliminate some of the things that couldn't be, that don't make sense, right? Like here, I'll give you one of the choices you should eliminate is C, right? Because we know the settings should be different for someone with status asthmaticus versus an OD with maybe ARDS, et cetera. So that's always a good strategy when you're not sure what to pick. But go ahead, pick your answer.
I'll go with A.
Okay. Very good. Very, very good. See, and he thought he was picking on you because you get it wrong, but we knew, Carly, you'd get it right. We had faith in you. So yeah, patients are hypoventilated to maintain elevated PCO2 levels to keep their airway pressure at safe levels to avoid barotrauma, right? And they should have slow respiratory rates. They should be allowed to have permissive hypocarbia. And barotrauma causing a pneumothorax should definitely be avoided. That'll kill them.
All right, Rayber, you can pick somebody, and you can also have the option of calling out for somebody in the conference room, and I can pick someone in the conference room for you too if you don't want to go through Zoom.
Ooh, pick someone live.
Pick someone live? All right, we're going to go with Chief Shah.
Oh, now you, and he called you the chief too.
See, cardiovascular one.
Okay. So a 50-year-old man presents with crushing substernal chest pain for 30 minutes. He is pale and diaphoretic. BP is 85/60, pulse is 64, respiration 16, afebrile, satting great. He has distended neck veins and clear lungs. His EKG is shown below. Give you a chance to look at the EKG. Okay, and your choices are, after giving him an aspirin and alerting the cardiac cath lab, what is the most appropriate next step in management? A, nitro, morphine, and O2. B, normal saline bolus. C, oral beta blocker. And D, vasopressor therapy. So all yours. Okay, very good. So normal saline bolus is needed to resuscitate this patient with a right ventricular infarct. They love this kind of question. It's been on the last 3 in-services. Preload reduces like nitro should be avoided. He's already hypotensive. So right away you can eliminate that. You're not going to give nitro to someone who's hypotensive, right? So again, you're always thinking, if you're not sure, what can I get rid of and then take my best shot? His EKG shows an inferior wall STEMI with the ST elevation greater. Everybody see that? Thanks for putting that back on, right? You can see that inferior wall STEMI, ST elevations in 2, 3, and F, and ST depressions in 1 and L. So you know this is really acute. There's also some ST elevations in some of the precordial lead. And then In lead 3, if you look at that closely, the ST elevation is greater than that in lead 2. That's a clue to a right ventricular infarct, right? And then you definitely, anyway, with any inferior MI, always get right-sided leads. And if you do, you would see ST elevations in those right-sided leads. So there's a right ventricular infarct as well as an inferior infarct. And if they're hypotensive, you should give them fluid. So very good.
All right, Shah. Also in the room or on Zoom? All right, Alan. Peds 1. So a 5-year-old female presents to the emergency department for falling off a slide and has right wrist pain. Initial x-rays are normal, but the patient still has pain. What is the next best step in management? Discharge home with peds follow-up in 2 days, ortho consult and admit for repair, ortho consult and cast, splint discharge with ortho follow-up in 1 week, splint discharge with peds follow-up in 2 days. Is it D? And it is D.
Very
Good. So this is a kind of a treatment type question, and they give you a lot of different options, and it might be tough to kind of tease out which could be the correct one. But you can start to see a little bit of a pattern here, right? You have the option of, do you need ortho right here, right now, or is it going to be outpatient? So you can kind of divide up these answers into those two halves. And right, everything's normal. The patient doesn't have any X-ray, doesn't have anything on the X-ray, so you're not going to need to do any orthopedic repair. You probably don't even need to do a cast. So you can kind of, I think, eliminate those two the easiest. And then it's about what the follow-up's going to be. So you have to remember, in pediatrics, they love talking about Salter-Harris fractures. And right, your Salter-Harris 1, you might not see anything on imaging, but you have to consider that there could still be a growth plate injury. So you want to be careful with it. That's why you want to splint. And you could do peds follow-up, but really you need orthopedic follow-up to reassess and decide, could there be any other injury that would potentially affect this child? So that is the correct answer.
And just one other point. What we might do in our institution is not always what the classical thing is. This is aimed more to what most physicians out there in the community are doing. So you, as was mentioned by Dr. Sell, you don't have ortho in-house, and what are you expected to do? And you're expected to know how to splint it, and you're expected to know when you need ortho as a stat and when you can just call them and make and get an appointment for a couple days or a week or whatever you need.
All right. Let's get to somebody on back to Zoom. How about Raboyo?
Okay, I'll do trauma 2.
Trauma 2. A 55-year-old female presents to the emergency department after a motor vehicle collision with significant damage to the vehicle. The patient is awake and alert, but confused on primary assessment. You have a head CT. This is what it shows.
Okay.
Which is the next best step in management? Antibiotics and trephination, hypertonic saline, discharge with follow-up imaging, elevate the head of the bed to 30 degrees and control blood pressure, repeat the head CT in 6 hours. Right, and the key for this question is to really read the actual question itself.
I think D.
And you think correct, right? So I like this question because a lot of these choices could seem reasonable, depending on what happens with the patient. But they're really asking what's the next best step. And so you would want to at least do your conservative and your basic measures right to try to control intracranial pressure, right? So you want to elevate the bed and control the blood pressure. This patient is a little confused, but patient's awake, alert. There's no midline shift yet. You wouldn't get this CAT scan, and the first thing you do necessarily go straight to trephination or anything else like that. First, you want to do all of your simple steps. And this is a favorite question or style of question that they ask on the boards: is the next best step or your initial step? Because they want to know, are you doing things in the correct order? Sometimes they'll say it's the definitive, and they want to know what's the final thing you're going to do that's going to manage something. So the key for this question, because it might be tough to tease out some of these, is to just really read the question and say, well, what would be the actual next best thing that I would do when this patient got back in the room from the CAT scan? So very good. All right, Raboyo, pick on somebody.
Okay. There's mostly seniors here. Christina.
Okay. Psych.
All right, psych.
Which of the following statements regarding diagnostic features of substance-induced psychotic disorder is correct? A, alcohol-induced psychosis typically involves olfactory hallucinations. B, amphetamine-induced psychosis usually involves persecutory delusions. Cannabis-induced psychosis can involve formication. And cocaine-induced psychosis symptoms can persist for several weeks. So that's a hard one, Christina.
Yeah.
What do you think?
I'm gonna guess D.
Try to eliminate certain things. You might know at least one or two, and then try to pick what you think is best. Take your best shot.
You got it.
You got it. So yes, cocaine-induced psychosis can persist for several weeks. As can amphetamines and phencyclidine, PCP. Cocaine and amphetamine-induced psychosis can be associated with formication, but not the choice they gave you, right? Cocaine-induced psychosis is often a paranoia regarding being followed or watched. And cannabis-induced psychosis, which is rare, but usually involves persecutory delusions. Very good.
All right, Kopchak.
Adrian.
Let's do Tots, the first one. I mean, the only one.
All right. So you have found the first double jeopardy, Orchicea. So this is going to be a 2-point question, but it's going to be a little different in that there could be no correct answers, or there could be multiple correct answers. So you have to select either the right combination or none or all to get both points, okay?
Okay, please choose all that apply. The difference between the clinical presentation of an overdose with Jimson weed and that of crystal meth is that Jimson weed will cause, so 2 things that differentiate Jimson weed from crystal meth. So you have to know what kind of overdoses they both are. Your choices: A, dry skin; B, altered mental status; C, dilated pupils; D, decreased bowel sounds and ileus. Where's Noah when you need him, huh? Okay.
I want to say that Jimson weed will cause a dry skin.
Because what?
A dry skin.
Okay, there may be more than one. So you don't get any credit unless you get the more than one. There could be 4. There could be, but what's the difference between both? Is it only that one, dry skin? Or, okay, so
that
clock is ticking.
A and D.
All right, let's see. So the answer is A and D, like A and D ointment. So Jimson weed is an anticholinergic and will cause dry skin and decreased bowel sounds. Crystal meth is a symphomimetic drug, like cocaine, that causes diaphoresis and does not decrease bowel sounds. They both cause altered mental status and dilated pupils.
And they love to ask questions like this for talks on the exam. They like the physical exam findings and how to differentiate just on the physical exam. Occasionally, they might show you pictures of different plants or things like that. And on my boards, I had one that they showed me seed pods and things like that, and you had to know what they looked like. So just know what each of the anticholinergic and sympathomimetic and what type of symptoms they could produce, but also just kind of compare them to some of the common tox things.
Good.
All right, Orchid, I'm going to throw it to someone in the room here, okay? So let's go with DeBella. GI. All right, so a 43-year-old woman presents with epigastric pain, nausea, and sweating after meals with watery diarrhea. She underwent gastric bypass last week for morbid obesity with no immediate complications. Vital signs are normal. Which of the following is the best initial treatment for her likely diagnosis? So dietary modifications, factor 10A inhibitor, IV antibiotics, surgical consult, or vitamin supplementation. And if you know one that's definitely not right, shout out which one you don't want to pick. Gonna go with A, tentatively.
Very good.
So good. So I put this on because I like to also bring up questions for patients that we don't typically see here. And so now we have bariatric surgery at Kings County, but right, we don't see a ton of patients who have certain procedures or certain devices put in. So this is a definition of dumping syndrome. This is after having gastric bypass, your contents of what you eat, if you eat too much or too frequently, if the food travels from the stomach, which is now smaller in cavity, into the intestine before it's fully digested, it causes this syndrome called dumping syndrome, which is this sweating, epigastric pain, watery diarrhea, nausea. It's an influx of water because of all the osmotic difference from all the food that hasn't been digested yet. So this is pretty common, especially for patients who haven't gotten used to what their new diet will be. So the first thing to try is dietary modifications, and that includes smaller meals and drier meals to allow for easier digestion and less chance that it's going to move into the small bowel before it's completely digested in the stomach. So just remember, things that you do not have any potential clinical experience seeing in the ED can be on the test. So they're always good topics to go over different questions and different subjects, so you have a good base on where to go for. All right, DeBella. You can pick either in here or on Zoom. What do you want? All right, Warshaw.
How about dermatology?
Oh. A mother from Williamsburg brings in her 18-month-old son because of fever and a rash for 3 days. He also has a cough, coryza, conjunctivitis, and small blue spots on a red base seen in his mouth. His erythematous macular rash started on the face, but is spread all over the body. Picture the rash as seen below. There's the rash. And what is the most likely diagnosis? A, erythema infectiosum, B, rubeola, C, rubella, and D, roseola.
It's rubeola. It's measles.
Yeah. So there's rubeola. So one of the things that they do on the board, and people have heard me use this term before, but there's a saying in Yiddish, if magib nemt, if they give you something, take it. So the boards are much really different than real life, right? In real life, there are a lot of red herrings, things that the patient may have that are ambiguous or don't really relate to the disease. If they give you something on the board, that is relevant almost always. So the fact that the patient is from Williamsburg is important because we know there was an epidemic out there, right? On the board, they'll give you things like it's summertime and someone is hiking in the mountains. And then you say, hey, Lyme disease or poison ivy, right? Or someone is out in the Southwest in the desert and gets bit by something. Oh, rattlesnake or scorpion, right? So you always want to, when you see those little clues, you grab them, you know? So anyway, measles is caused by a highly contagious myxovirus. It is characterized by the 4 C's, coryza, conjunctivitis, cough, and Koplik spots. The rash starts on the face and spreads to the trunk and coalesces into an erythematous rash. Complications like pneumonia and encephalitis can occur.
Great. I'm going to throw it back to Zoom. Let's see. Kenny, you there?
ID for 1.
ID.
Okay, a young woman has a fever of 102 and a red, swollen, painful right knee. And this rash, what is the diagnosis? So your choices are septic arthritis due to Staph aureus, B, rheumatic fever, C, GC arthritis dermatitis syndrome, and D, bacterial endocarditis. So what do you think, Kenny?
C.
Very good. So this is gonococcal arthritis dermatitis syndrome, right? Most common acute septic arthritis in a young woman, right? It is characterized by arthralgias, tendinitis, septic arthritis, and a vesicular rash on an erythematous base that becomes pustules and then necrotic lesions. You culture fluid, blood, and genitalia. Very important. Even if it's an arthritis thing, and sure, you're going to tap it if you can and get the fluid, and you get Paul Hine to help you tap the joint. But you always actually culture the genitalia as well, and that's been on the board. You admit they should not be sent home, and they admit an IV ceftriaxone and either azithro or doxycycline.
Great. All right. Why don't you pick someone on Zoom, Joe?
Just a quick question for the last one, just because I know that we're no longer giving azithro for regular GC. Are we still giving it for?
Yeah, so that's why I put that there, just to actually make that point. So for regular GC, uncomplicated, now if you're not sure even that there's no chlamydia there, let's say, so you just have urethritis or cervicitis, uncomplicated, not a terrible PID, not, a septic arthritis syndrome. The treatment now is to get the GC, it's the 500 of ceftriaxone, unless you really weigh a lot, like 300 pounds, and then it's actually 1 gram of ceftriaxone. And if you can't rule out chlamydia or doxy, then doxy now is the treatment unless you're pregnant, and it's 100 BID for 7 days.
But the key to remember is all these changes just happened, right? So all of the new treatment algorithms are not going to be on the test, or right, they're not going to be basing it on that. Usually it takes a few years for the questions to be rewritten. So just keep in mind that things that you might have learned a few months ago or during the year before your exam might not be on the test. There should be some fairly standard things that have been used over the past few years without any controversy.
Okay.
Kadaki, you want to pick one?
Sure. Let's do gyne.
All right, gyne.
So during an imminent delivery in the ED, the infant's head is easily delivered, but the body delivery does not progress despite downward traction. Which of the following maneuvers will help alleviate this fetal presentation? A, adducting the anterior fetal shoulder and then rotating the shoulders 180 degrees. B, displacing the fetal head back into the birth canal. C, hyperflexing and abducting the mother's hips. And D, palpating the abdomen externally in all 4 quadrants. Right?
I'm going to say the answer is C.
Which one?
C.
C, very good. So this is the McRoberts maneuver. It should be performed first to treat what? Well, this patient has shoulder dystocia, right? Sometimes they'll even describe it as a turtle thing. The head comes in and then gets pulled back out, goes out and then comes back in. The Woods corkscrew maneuver, which was A, can be attempted if the McRoberts maneuver fails, especially if you do McRoberts with suprapubic pressure. And then pushing the heads back into the birth canal is the last resort. Always call for help early and consider doing an episiotomy. And remember the helper mnemonic. And on every single training that I have seen in the last few years, there has been questions on this. So you should know about complicated deliveries in the ED. There'll definitely be a couple questions on it.
All right, so now for the essence of time, we're not going to be able to get through all of these, obviously. So we're going to go to these. I have 2 final questions, going to be worth 3 points each. Everyone's going to be answering these kind of together. So I'm just going to randomly pick Dilip. You're going to be the senior representative. And let's see, who else is here? Trying to find one other junior. And Anthony, you'll be the junior representative, okay? You guys can all kind of talk amongst each other. There's going to be 2 questions. They're both related to cardiac devices. These are pretty heavily tested, and definitely last year they were heavily tested, so I wanted to specifically go through these. So I'm going to get an answer from Dilip and an answer from Anthony for your teams, respectively, for this first question. So a 69-year-old man, status post pacemaker placement 6 months ago, presents with palpitations, and this is what the telemetry strip shows. And I will come back to it. So what is the initial diagnosis? Broken lead, failure to capture, failure to sense, oversensing, or PVCs? I'll give a minute or so for everyone to
Worth 3
debate it.
points?
3 points.
3 points. Don't let your team down. Pressure.
Okay, none of the juniors are chatting me. I need help.
I can pass on what the juniors in the room are saying. Juniors in the room, what are you thinking so far?
I've gotten 2 contradicting messages. I need a tiebreaker.
Okay, I think I know what it is. I got 1 confirmation from someone.
Okay.
I think it's
Okay, I have a
E, PVCs.
okay, I have a consensus, I think. Can we go back to the answer choices?
Yeah.
Consensus seems to be C, failure to sense.
All right. And failure to sense is correct. So pacemaker questions, there's usually 1 or 2 on the test, and I feel like this is the style of question that's asked the most, which is to troubleshoot when a pacemaker isn't working properly. So, right, sensing is the ability for a pacemaker to sense a native rhythm to decide what to do. So here, if you look at this rhythm strip, you see pacer spikes that are still occurring even though there's a native beat going on. So that means that it's not sensing or failing to sense that you have a native rhythm and is triggering shocks and beats, even though the patient's native rhythm seems to be working. Oversensing would be the opposite. It's where you think the pacemaker thinks that your native rhythm is there, but in reality, it's some artifact or some motion or something. And when it should be delivering a pace beat, it's not pacing. The other choices, broken lead might show no pacing spikes at all because there's nothing connected to the heart. Failure to capture would be you're seeing pacing spikes appropriately, but there is no beat afterwards. And then PVCs would be the right answer if there was absolutely no pacing spikes at all and you're still seeing these types of complexes. So good. So these are tough questions, which I why I put them at the end. But this is something I would highly recommend just going over, doing a bunch of pacemaker questions before your exam. All right, final number 2. A 52-year-old woman with a left ventricular assist device presents with lightheadedness for 2 days. She reports no LVAD alarms prior to arrival. She's awake, pulses are not palpated, but MAP performed by a Doppler is 53 millimeters of mercury, and pulse ox is 100%. On exam, the LVAD hum is present, lungs are clear, and there's 1+ peripheral pitting edema. The ultrasound shows a large right ventricle and a small left ventricle. INR for the patient is 2.8. What is the most likely cause of her hypotension?
4 questions on last year's in training on LVAD. 4 questions.
Oh my God, I've gotten like 5 different answers.
Well, it's a hard question.
Oh, and we don't see this often, as Dr. Hassel mentioned. It's why he wanted to do this, because these are things that we don't see often, but other places, right? Columbia Presbyterian sees this, Cornell sees this, right? Mayo Clinic sees this. So these are going to be on the test, because they're not just thinking, oh, let's do it for Lincoln, let's do it for Kings County, you know, let's do it for LA County. No.
All right, final guesses.
E, right ventricular failure.
All right, so we got a right ventricular failure. One guess, and
Our guess as well.
your guess as well. And they're both correct guesses. So
Very good.
So just to kind of go through this, for questions like this, it's good to really go through each of these answers and see which one is really unlikely. So hemorrhage can be a complication because patients are on anticoagulation, lifelong for LVADs. But we're not getting anything here on the question stem, any signs of any type of distress for hemorrhage. So that's a pretty easy one to kind of rule out. An LVAD malfunction, I mean, they say there's no alarms. That's usually good enough to say that the machine itself is functioning the way that it was programmed. So that kind of leaves the bottom 3. Pump thrombosis is pretty rare, but it can happen, especially if the patient is not correctly on their anticoagulation, but the INR here is therapeutic. So same thing, they're not giving you any reason to think that could be happening. And furthermore, with a pump thrombosis, you should see a dilated left ventricle and right ventricle because everything is backing up in the heart. So that leaves with a massive PE versus right ventricular failure. A massive PE might present with, some right-sided dilation, but same thing. The INR here is normal. The pulse ox is 100%. The patient's not really presenting with any other symptoms other than this mild lightheadedness, so it's less likely. And right ventricular failure is the most likely cause then. The lungs are clear. The LV is actually small, so maybe the LVAD is working a little too well. Maybe it's pumping a little bit too much. But LVADs, right, only affect the left side of your heart. They don't help the right side of the heart. So treatment for this patient just in real life would be the same for any other right ventricular, right-sided heart failure. You'd have to consider talking with cardiology about giving fluids versus inotropes or things like that. John.
Question, right? Like, what is the etiology of ventricular failure? This doesn't sound like left side failure. The lungs aren't overloaded, so it's not a afterload issue, it's more like a preload issue. What would you recommend? I mean, I guess you because preload is a way to treat this patient. If you think that's a cause.
Yeah, these are ones it's tough. Just like right-sided heart failure is tough to treat too. In real life, you would talk with cardiology to see, hey, should I be giving some inotrope here to try to help through? Do they need more preload? Because this is a preload dependent thing. It's really tough. Now, what causes right ventricular failure in these patients? Probably whatever underlying had caused the left ventricular failure. It could be ischemia. It could be other things like that.
You've already almost said the LVAD, right? The LVAD should be decreasing whatever it's triggering the biggest department in the building. It's crazy. And to not have it.
No, not really, right? Because all the LVAD does is just compensate for the fact that the left heart can't squeeze anymore. So there could still be a whole bunch of underlying factors that could still lead to right-sided heart failure.
I mean, I think it would be reasonable, as always, to try some fluid cautiously, as long as there's no signs of increasing left heart-sided failure. And then meanwhile, all these patients with LVAD will have with them cards or a phone number on the machine. And They are people who are real experts that you can call 24/7. So you can try fluid and then try to get in touch with the experts, and they will give you guidance. Even here, the first LVAD I saw, the cardiology fellow had no clue what to do, right? I had to wind up calling Columbia.
All right, so just for these questions, practice, like try to find some questions, practice them. They're in all of the different question banks that you have access to. And it's really going to come down to physical exam findings. Usually there's going to be an echo with ventricular size, as well as then other evidence for thrombosis versus infection. So just kind of have these in mind. Searles.
I was going to say, on my actual boards, there are about 5 questions of LVADs.
There you go. Searles says on his board exam, he had 5 LVAD questions.
And
So
also, for pacemakers, make sure you know the 4-letter arrangement.
and he's just he's bringing up that for the pacemaker questions to know your 4-letter designations on how they function, and that they'll ask you questions on it. So
You guys want to read something on pacemakers? D'Souza wrote
Yeah.
a very nice EBM that really explains it very, very well. I highly recommend.
Silverwood's recommending D'Souza's EBM article on how to read pacemakers. It is a really good read and a good summary. So it's something to kind of look at between now and the test.
Yeah, and 2 weeks ago, Ian gave a great board review on cardiology, and there was a few questions on pacers, and you can see, obviously, he's a real expert.
So good. So congratulations. Seniors have taken one and bring it one closer to the junior versus senior board review challenge. So look, what was the point of this? Really, it's to show you that you really should be doing a lot of questions in order to prepare for this test, right? Just knowing good medical knowledge in the clinical area might not translate, especially when it comes to multiple choice questions. But you don't need to be the brain. You don't need to be Mr. Perfect here in order to pass this test. You just need to get enough right to pass the test. So do a lot of questions, study the topics that are the heaviest hitting: signs and symptoms, cardiology, trauma, respiratory, GI, ID. That makes up about 50% of the test. Practice your test taking tricks, especially as you're going through your practice questions at home. Really try to utilize not only your medical knowledge, but different phrases, ruling out answer choices, using the answer choices to guide you what subject that you're on. And ultimately, sometimes just need a little bit of luck. You're not going to know what the answer is, and it's okay to have a little bit of luck to get some of these right. I certainly didn't get all my questions right on my boards, and I passed. So,
but don't let that upset you. If you don't know an answer, take your best shot, eliminate the crazy ones, take your best shot, and move on. And then you can mark them, and if you have time, you come back. But you don't want to leave anything blank. Getting something wrong costs you the same point as if you leave it blank. So answer everything, and then you have time, come back, and then take your best shot. And a lot of studies on test-taking techniques show that usually, if as long as you read the question correctly, that almost always your first impulse is the right one, as long as you first read the question carefully.
good. So thank you guys for participating. If you have any questions about this, obviously just email me or Dr. G. And we're available for any help for studying for the in-service for your boards. Obviously, we do the oral boards too, but just reach out to us. We're more than happy to talk about questions, specific ones that you had questions about when you're doing your practice, or any guidance you need. We're here for you guys. So thank you.
And a board review today by a really great teacher, Dr. Holt, who's one of the best clinicians here, but he's also really good on this derm thing he's going to do today.